Here's a finding from one of our speakers from last year. I hope that some of you were able to hear Greg Brown talk. Greg's a researcher at the University of Pennsylvania doing really groundbreaking work on treating suicidality with cognitive behavior therapy, which is proven, I think, to be the most powerful treatment yet of a psychosocial nature to try to reduce suicidality. Actually, in psychopharmacology, we only have 2 drugs that have been proven to reduce suicidality. It turns out that that's lithium and clozapine. But in this particular study, patients that received 10 sessions of CBT, which was focused somewhat on helping people develop anti-suicide plans and to rehearse those and to develop skills to manage their dysphoria when they were thinking suicidal thoughts, that their suicide attempts were reduced about in half compared to a treatment as usual. In fact, this was actually better than treatment as usual. It was an enhanced care model. They didn't receive CBT, but they received very close monitoring. So that's a very exciting finding, I think, that we need to pay attention to. So if we're working with people with depression, we want to reduce their suicidality using CBT techniques. It's very promising. If you're working in inpatient settings, I see some nurses that are doing that, using these techniques with people that come in that are desperately suicidal. It's an important thing to do, and also in our outpatient work. Here's a slide showing some of the work we've done here at the University of Louisville on computer-assisted therapy. In this particular study, we assigned people to computer-assisted therapy, standard cognitive therapy. They got treatment for 8 weeks. They only had 9 sessions altogether. In computer-assisted therapy, they had 4 or less hours of contact with a clinician. This is a model in which the clinician and the computer work together as a technology-human team, if you will. So it's not just a patient goes and sits at a computer terminal. They also were assigned to a wait list, and nobody in this study got medication whatsoever. And we saw at the end of 8 weeks that there was a fairly dramatic reduction of depression scores, and there was no difference here between the computer-assisted therapy and the standard therapy, even though the amount of treatment time with the clinician was cut about in half. And then these findings held up over 3 and 6 months, even though treatment stopped. The thrust of this work is to try to deliver therapy to places where it might not be available, to improve the efficiency of therapy, to allow more people to be treated with available resources. There is a hint here, which you'll see in the next slide, that computer-assisted therapy, even though it had less clinician time, this could be sobering to us that like to practice psychotherapy, that if the computer was involved, the people in some ways did better. This is a dysfunctional attitude scale, which is a well-known instrument that measures core beliefs or schemas. And it turned out that those who received the computer-assisted therapy actually did better in changing their core beliefs than those that got more time with a therapist but did not get the coaching and interactive learning experience on the computer. There was a bit of a slight, non-significant trend for improvement in automatic thoughts. This is the automatic thought questionnaire. And this is an instrument called the Cognitive Therapy Awareness Scale that measures how much somebody learned about cognitive therapy, what kind of skills they acquired during their treatment. And again, the computer-assisted therapy had an edge over standard treatment. Now, this needs to be replicated, but it does suggest a possible promise that by technology intersecting and being collaboratively utilized with a clinical application of cognitive therapy could possibly enhance overall outcome. So we're hoping to do further research here at the University of Louisville on this particular form of treatment. Here's another slide that I found very promising. Shows that CBT has been useful in the treatment of bipolar disorder when added to medication. Now, we never treat bipolar disorder with psychotherapy alone. Obviously, this is a condition that has strong biological roots and needs to be treated with medication. But it turned out in this study that the relapse rates were substantially reduced when CBT was added to medication. And this afternoon, there'll be a workshop, if you're interested, in which I'll explain how CBT is used with bipolar patients. Lastly, I just wanted to echo what Alan Tasman said about our depression center at the University of Louisville. I think that these depression centers that are being started up all around the country in the National Network of Depression Centers have a big opportunity to make a difference in the treatment of depression, not only in providing cutting-edge treatments, doing education like seminars like this and to the general public, but also to stimulate more research along the lines that I've demonstrated today. Here are some of the things that we're doing here at the University of Louisville. Our clinical center has programs developed for children, adults, and geriatric applications. We've already developed evidence-based guidelines that we're implementing. We have educational programs like the ones we have today. We're doing multidisciplinary research on both the biological and psychological, psychosocial aspects of mood disorders. We have a strong women's program that's being developed under the leadership of Joyce Spurgeon. We're just beginning to develop a disease management program. If you're interested in that particular application, you might want to talk with us about whether you'd like to be involved with that. The disease management program attempts to improve the overall treatment of depression across broad populations, to monitor outcome, and to use evidence-based guidelines. We have an ongoing CBT training program, which we have, meets every Wednesday at 11 o'clock, and those of you that might want more training in CBT might avail yourself of that. We have a computer-assisted therapy suite, which now has computer-assisted multimedia programs like we've developed here, and will very shortly have virtual reality exposure therapy. That will be installed in December, and if you have patients that might need that type of therapy for things like social phobia, fear of flying, other kinds of phobias, and related anxiety disorders, we'll be able to have that very interesting and highly effective treatment available. And then lastly, there'll be a membership system that will start in 2009. This is a system that's very similar to what's done in cancer centers, so that clinicians who want to associate themselves with a depression center can do so. And by doing that, we will help them with evidence-based guidelines, with education, helping them if they want to get research studies going on, and in turn, they'll help the depression center reach its goals. So we'll have more information about that that will circulate.